So cardiac output equals heart rate multiplied by the stroke volume, which is essentially a difference of end diastolic volume minus end systolic. So when we talk about the regulation, we talk about our ability to manipulate all these parameters to increase cardiac output. And this is something that I want to make very clear. Generally speaking, we don't need to decrease cardiac output. Does that make sense? You are at the baseline. When you start being active, you need to increase cardiac output. When you relax, the cardiac output goes to the baseline. You never need to go beyond the baseline, below that. Am I clear? This is what we focus on. We consider making it, sort of higher, okay, a better thing. So let's first start with the concept that is called a preload. And the related concept, Frank Starling. So what is the Frank Starling law? For cardiac muscle, higher muscle distension corresponds with a higher force of contraction. A lot of spelling problems. Does that make sense? That's the Frank Starling law. Now, what is that? Imagine that you have a lot of blood, or higher venous return. Now, do you understand? Do you kind of, do you understand what it means when I say venous return? That's the blood that goes back from veins into the atrium. Does that make sense? So you have higher venous return, which means higher end diastolic volume. Does that make sense? Okay, so you have more blood in the ventricle. But interestingly enough, when you have more blood in the ventricle, it means higher distension of a ventricle. Higher distension, higher force of contraction, and voila, all this blood, all this EGV, well, not all, but a lot of it, goes into the bloodstream. Does that make sense? So essentially, if we want to summarize it, higher venous return means higher EGV means higher cardiac output. Higher EGV, higher cardiac output. Does that make sense? You clear? And this can happen because heart pumps stronger and can squeeze out all that extra blood. We good? Does that make sense? Blink or yes, nod, something like that. What could increase venous return? Few things. First, decreased heart rate leads to the increased venous return. Now, it may sound counterintuitive, but think about that. If you have a decreased heart rate, heart has more time to fill up. Does that make sense? It just simply, now, I had someone asking on Wednesday, so like, what's the trade-off? There's no trade-off really. Imagine that you are an elite athlete. In elite athletes, usually heart rate is pretty low. So they may have resting heart rate at 50. If that would be any of us, we would die. Well, not die, but we would feel very uncomfortable. But in those elite athletes, that massive distension of the heart leads to a powerful contraction that, because they have such a high venous return, they can afford lower heart rate. High venous return, high EGD, high heart rate. Does that make sense? What else can increase venous return? Muscle and respiratory pumps. Okay? So what is the muscle pump? Imagine that you have two muscles. Okay? That's two muscles. My palms are muscles. And blood, the vessel goes between them, the vein. When muscles contract, they widen out. Do you see that? They widen out. And therefore, they will squeeze the veins between them. And they will squeeze the blood towards the heart through the veins. Does that make sense to you? What's the respiratory pump? When I inhale really hard, my chest expands, my abdomen contracts. So blood is squeezed from my abdomen towards my chest. That's respiratory, towards the heart. Because look, returning blood from here or from here isn't a problem. From here, it's the work against gravity. That makes sense? So generally speaking, to kind of conclude the preload story, higher preload, higher cardiac output, higher endoscopy. Now, kind of last bit that I want to illustrate. When your muscles contract when you breathe really hard, what does that mean? You're doing what? Your muscles contract, you breathe really hard. What you're doing? Exercise. So this is how you can increase your cardiac output during exercise. Does that make sense? Good? Clear? Okay. Next concept. Contractility. Ability to contract. Or, no, sorry, don't write ability to contract. Force of contraction. At a given distension. Okay? I feel that I misspelled distension, but I'm not sure. I don't know. Okay. Now, what does that mean? It means how hard the heart pumps, how intense it is. Does that make sense? So now look at this. I really want you to make a mental effort here. This is your heart. If it pumps kind of okay, it squeezes a certain amount of blood, right? If it pumps much harder, it squeezes more. Does that make sense? So elevated contractility Which parameter in this equation is it going to change? When your heart squeezes stronger, which parameter is going to change? Huh? No, not about frequency. Huh? Right, but which parameter out of these three? Well, we figured it's not a heart rate. I can give you a hint. For now, we're going to talk about three things. They're going to relate to only these two parameters. So to narrow it down, when your heart squeezes, harder, which parameter of these two is going to change and how? How? So when your heart squeezes harder, ESV is going to decrease. Does that make sense? Do you understand that? Good? Everybody's clear on that? ESV. Think of it. Look. Imagine that your heart is a towel. You soak this towel in the water, okay? And you ask a 4-year-old to squeeze. The towel's going to be pretty damp at you, right? Because 4-year-olds are not generally very strong. Right? And then you take the same soaked towel and you squeeze it yourself. You squeeze out more, so the towel contains less. ESV is how much your heart contains at the end of the system. So ESV is down. And how does it affect cardiac output? Yes, it can go up. Okay, now, what increases contractility? Sympathetic stimulation. Okay, elevated calcium. And I'm going to expand on the sympathetic stimulation. It's epinephrine, norepinephrine. Okay, elevated calcium, thyroid hormone. Does that make sense? Good. And in general, anything increasing calcium availability. Okay. So this group of physiological factors called positive ionotropic agents. Does that make sense? Good. So if somebody has sort of a feeble heartbeat, sometimes you can just do the IV calcium chloride injection. Sterile calcium chloride doesn't do it sometimes. Now, what decreases contractility? Elevated potassium ions, acidosis. This is called negative ionotropic agents. Does that make sense? And obviously, if you have decreased contractility, decreased cardiac output. I have a very simple question. Really, like 0 out of 10. Did I ever mention parasympathetic system? Parasympathetic. Did I ever mention parasympathetic system? No, I did not. It's interesting that only sympathetic system has an effect on contractility and it increases. Does that make sense? Parasympathetic has no effect on contractility. Are we clear? Now, third parameter. It's called afterload. And we're going to work on afterload with you together. So imagine somebody has high blood pressure. Higher than normal. When your ventricles start pumping into the, let's talk left ventricle and aorta, okay? When left ventricle pumps into the aorta, if pressure in the system, in the aorta, is higher than normal, which parameter of these two will be affected? That's kind of 3 out of 10. If pressure in the aorta is higher than normal, which will be affected, EDV or ESV? Yes. How? Say again? Think of it this way. You are pumping something out, but you pump against greater pressure. You pump against greater resistance. Does that make sense? So in fact, in the people with elevated blood pressure, you're going to have higher resistance to pumping, which essentially will lead to increased ESV and decreased cardiac output. Does that make sense? Are we clear? So we can kind of say that high afterload leads to decreased ESV and increased ESV and decreased cardiac output. Okay? So far, are we clear? Any questions? Good? To kind of wrap it up. High preload, equivalent to high EGD, which means elevated stroke volume, elevated cardiac output. Does that make sense? High contractility responds to lower ESV, higher stroke volume, higher cardiac output. High afterload, though, responds to higher ESV, lower stroke volume, lower cardiac output. We good? Okay, heart rate regulation. Now, I'm going to write only one thing, but it's no-brainer. Elevated heart rate leads to what change in cardiac output? Yes. Now, what can increase heart rate? Sympathetic stimulation, calcium, and sympathetic stimulation, you already know that this is epinephrine, norepinephrine, right? Calcium, thyroxine. Okay? Now, so heart rate can be increased by sympathetic stimulation. When you exercise, when you're stressed and shit like that, okay? Direct increase in calcium, it's unlikely that it's going to happen to a healthy person, you know, or thyroid hormone. Now, what can decrease heart rate? Parasympathetic stimulation, essentially forward, okay? Elevated potassium and acidosis. Now, hear me out. For contractility, does parasympathetic system have effect on contractility? No. Does it have effect on heart rate? Yes, it does. Does that make sense? Now, before we move any further, I know that sometimes you like to take a picture of this. If anyone wants to do it, the time is now because I'm going to kill some of that stuff. Hey, you have a question? Any picture takers? Good? Okay, then I'm going to kill a part of it. I'm going to leave the this one for some time. So what I want to address now is the regulation of cardiac activity by the CNS. And it's going to be very schematic, okay? That's heart. That's medulla oblongata. Okay? This is specifically nervous regulation. Am I clear? Does that make sense? So, one branch is parasympathetic. So, parasympathetic, cardio, inhibitory center. Okay? Decreases heart rate. This is fibroscope. Are we clear? Another branch is sympathetic. Okay? This one increases heart rate and contractility. That's thoracic spine. Thoracic spine. Okay? The part. Okay. So again, highlighting it again. You have two centers. Oh, and I need to put that it's cardio acceleratory center. So if you are at rest, cardio inhibitory center is in charge. Does that make sense? It slows down your heart. When you start exercising first, that decrease in heart rate that's produced by cardio inhibitory center goes away. The heart rate starts to go up, and then cardio acceleratory center kicks in and speeds up not only heart rate, but also increases contractility. Does that make sense to you? You clear? The sympathetic system is affecting both contractility and the frequency of contraction. Any questions on that regulation? No? Okay. A little bit of like checks here. Oh, something that I forgot to just terminologically. So these ones are called positive chronotropic region. And these ones are negative chronotropic region. Bit of a break. Game. Let's just not let's not be shy and just answer. If it's wrong, it's wrong. It's fine. If someone has increased preload, which parameter that influences cardiac output will be affected? Increased preload means increased what? PDB. How does it affect cardiac output? How does it affect cardiac output? Increases. Makes sense, right? If a person manages to lower the blood pressure, which parameter will be affected? If a person manages to lower a blood pressure, yes, how? Decreases. And how does it affect cardiac output? Increases it. Very good. Now, if for some reason a person develops at rest tachycardia, elevated heart rate, how does it affect preload? Again? Say again? Decrease. Because remember, if you have higher rate of contractions, you have less time to feel the ventricle. Does that make sense? Less time, lower venous return, lower EDV, lower cardiac output, because I specify at rest. If at rest your heart starts beating faster, the stroke volume will go down. Does that make sense? Okay, good. Any questions on this? So there will be questions, more than one. I don't remember how many, and I'm absolutely sincere with you. On the exam, there will be questions. If blah, blah, blah changes, how does it change cardiac output, or stroke volume, or EGD, or ESC, or heart rate? Be comfortable with these terms operating, okay? I give plenty of such examples in quizzes, okay? I don't remember which quiz number. I think it's, well, 10 is the blood flow to the heart, 11 is physiology of the muscle. Yeah, it should be 12, cardiac cycle, okay? Make sure that you can work with it. Good? Made myself clear? Okay, a little bit of fun. Fetal cardiac defects. I mean, I know it sounds pretty terrible. So we basically can kind of group them in two big categories. Okay. One category is septal defects. Another kind of separate, tetralogy-of-Fallot. Transposition of great vessels, and aortic stenosis. Now, it's really a fairly simple matter. Okay? So what is a septal defect? In a fetal heart, if you have a heart here, okay? So you have two atria, two ventricles, right? In the fetal heart, there is a so-called foramina valve, a normal opening between the atria. And the ventricles, they have a defect here, E. Now, why doesn't it affect the livelihood of a fetus? Why do you need a separation of circuits? Why do you need a separation of circuits? It's a pretty hard question. Sounds incredibly simple, but it's a pretty hard question. The answer is very simple. Why do you want pulmonary and systemic circuits to be separated? Not in all animals, it's true. For instance, as far as I remember, in frogs, there's only one ventricle, two atria, but one ventricle. What blood is in the right side of the heart? Yes, deoxygenated, and on the left side, oxygenated. And when they separate, those two bloods do not mix. Does that make sense? Because you want to isolate deoxygenated and oxygenated blood in the heart. Why in baby? Well, not in baby, in fetuses. Why it's okay to let them mix? Do fetuses breathe? They do not. The gas exchange happens to placenta. Does that make sense? This is where they get oxygen. So it's totally fine to have blood mixed. By the time they're born, the septa should kind of fix the problem. But if they don't, then you have an exchange, a mixture of blood, fetuses develop cyanosis, and they have to be operated very quickly to fix the defect. Does that make sense? In many babies, those septal defects, very, very tiny, small, can last for a couple of years, and they don't really, they consider it to be normal. Eventually, that will grow, the holes will fill up. Does that make sense? Like, there can be little tiny defects. We good? Understood? Now, another special kind of defect that I want to illustrate here. So you can have atrial septal defect and ventricular septal defect. That's, both of them can happen. Either together, okay. Another defect that I want to highlight is the patent ductus arteriosus. So in kids, well, in fetuses, again, pulmonary trunk, okay. In fetuses, pulmonary trunk and aorta are connected to each other. Okay, so that connection is called patent ductus arteriosus. Okay? That makes sense. Now, FYI, the word patent, all it means is just old. Okay? So if this isn't fixed, if this doesn't disappear when by the time of delivery, then again we have another problem. Good? Patent ductus arteriosus. Now, tetralogy of Fetal, if my memory serves me well, which I'm not 100% positive about, okay? It's definitely ventricular septal defect, pulmonary stenosis. Now, are you comfortable with the word stenosis? Stenosis is narrowing down. So pulmonary trunk is narrowed down. Does that make sense? And since there's a ventricular septal defect and pulmonary trunk is narrowed down, the blood from the right ventricle goes through the hole. It's probably easier to draw. What you have. Okay? So the ventricular septal defect, you have aorta, okay? And you have really, really tiny pulmonary trunk. So the blood from the right ventricle goes directly into the aorta. And as far as I remember, I'm going to write down right ventricle to aorta. And as far as I remember, patent ductus arteriosus. So this is why tetralogy. So they are connected. Okay. That makes sense. Good. Now, what is transposition of great vessels? Look at this. Just look at this. There's something wrong. What? Pulmonary trunk and aorta switch. Does that make sense? So what happens, if right ventricle pumps in the aorta, blood goes into the system. It returns from the system into the right atrium, goes into the right ventricle, and goes back in the system. Does that make sense? Two circuits are completely isolated. This condition is incompatible with life. It can be with or without ventricular septal defect. So as far as I know, now there are surgical techniques that allow surgeons to fix this in utero, which is quite remarkable. Does that make sense? Now, aortic stenosis is a pretty simple concept. So you've got aorta, and inside of the aorta, you have a narrow. That makes sense? It can be, severity can be different. It will affect the manifestations. Usually what happens, and we didn't talk about the cardiac anatomy that extensively, but the heart is there. I'm too lazy to talk about it. But basically, well, if you look at the heart, if you look at the aorta, okay, okay, so this is aortic arch, okay? That makes sense. Heart is here, That's all. This is aorta. So this is brachiocephalic trunk. This is left carotid. This is left labia. Are you following? Now imagine there is a stenosis here. The blood is pumped from the left ventricle, goes into the aorta, then encounters that obstacle. How do you think this obstacle will change the pressure in that part of the aorta? Yeah. So you immediately have an increased blood pressure here. Does that make sense? Which leads to hypertension and cranial hypertension and upper extremities hypertension and hypotension in the abdomen, lower limbs, and so on and so forth. Does that make sense? Basically, it can lead to cyanosis and whatnot. Again, practically all of them are surgically fixable. Okay, but you got to have a good option. And for instance, I know that some, in regards to, I know that in many cases, some of the surgeries, when I was in Russia, regular cases when newborns were born with really severe defects, and the only place where they could get such surgery was Germany. And it was like $50,000, $70,000. People just taking it from crowdfunding themselves. And there was no such thing as crowdfunding because there were just no resources. Okay, that makes sense? Okay, any questions? Good? So the last bit for today is a brief conversation about blood vessels. Okay? So we're basically setting the stage for a discussion of blood pressure next week. So first set of blood vessels are arteries. The feature of arteries is that they carry blood away from the heart. There are three types of arteries. Elastic, they are largest. Muscular, medium size, let's put it this way. And arterial. Okay. Now, elastic arteries, they have no vasomotor responses. Okay. And I'll explain what it is in a second. Muscular and arterioles. Active vasomotor responses. Does that make sense? Now, what are elastic arteries? Elastic arteries are the biggest ones. So, well, I have this example. Aorta, subclavian, carotid, brachiocephalic trunk, common iliac, femoral arteries. Does that make sense? Now, what does that mean? No vasomotor responses. They do not constrict or dilate. The function of elastic arteries is to, now I don't want to confuse you, so I need to be very careful in my selection of words. They buffer the fluctuations in the blood pressure. They don't regulate the flow. Think of it this way. Imagine this is aorta. Look, this is aorta. When heart pumps, when there is cardiac systole, are you following me? When there is systole and heart gets in the and blood gets in the aorta, pressure suddenly rises. Does that make sense? So aorta can expand to alleviate that sudden change in the pressure. Does that make sense? That's what elastic arteries do. Vasomotor responses, meaning that muscular arteries can dilate and constrict, and they can regulate blood flow usually to organs or parts of the organ. Am I clear? Now, finally, arterioles. They are the smallest, about 100 micrometers in diameter. You don't need to know the number. They can dilate, they can constrict, they can regulate very local blood flow. Does that make sense? And what's important, they are also called resistance vessels. Meaning that these blood vessels will regulate blood pressure. Am I clear? We're good? Think of it this way. That's actually a pretty good analogy. Cleveland is so convenient in terms of, explaining how this whole thing works. Imagine I-90, okay? Wide, 3 lanes, everything's good, right? So especially that part between basically Painesville and outskirts of Cleveland, like Willoughby, 3 lanes, even 4, super wide. There's no chance you're going to have a traffic jam there, right? Then you go to Willoughby, and now you have 2 lanes to I-90, 2 lanes to 271, a lane to Ohio 2, like all this branching. That's your muscular, okay? But still, it's pretty good flow. And then you get into the street or ramp, okay? Ramp is your arterial. If the ramp is full, it doesn't matter how many lanes you have. You're going to have a buildup. Does that make sense? That's your pressure regulation. That's resistance vessel. We good? Veins to the heart. Okay. Now, smallest are post-capillary veins. Okay? Small veins, large veins. Now, what is common for practically all veins? Weak vasomotor responses. Okay, so can a vein constrict? Yes. Is it significant? When I worked with mice, we measured vasomotor responses in mice, in muscles. If you see a change in the venular diameter by like 20%, you call someone saying, look at this. This happened to me maybe twice over the span of 5 years. It's rare. Okay, does that make sense? So what allows the blood flow through the vein? We just talked about it. Muscular and respiratory pump. Remember that? Also, veins have valves. So this is a vein. This is the blood flow. Look, this is a valve. No, it's the other way. So, like this, right? So blood flow opens the valve, but if blood tries to go back, this is what's going to happen. Does that make sense? That prevents the backflow. And the third feature of veins is they are capacitance vessels. Okay? Meaning that at every given moment, 60% of blood in your body are in the veins. Does that make sense to you? This is what it means, capacitance vessels. Questions? And, well, we're going to talk about pressure. Let's leave pressure. Okay. Capillaries. Let me use this. They are between arteries, well, arterioles and post-capillary veins. Okay, now in terms of permeability, there are three groups of capillaries. Continuous, least permeable, fenestrated, semi-permeable, and sinusoidal. Right? Good? Now check this out. Continuous. Places like brain, muscles, skin, okay? Fenestrated, where you have some kind of exchange, like kidneys, okay? You following me? Or digestive, capillaries around intestine. Sinusoid, intense exchange. Bone marrow, liver, spleen. You have cells coming in and out, okay? Does that make sense? Now, in terms of the speed, these are the fastest, slowest. Does that make sense? Generally speaking, arteries are the fastest, highest pressure. Veins are the slowest, low pressure. Is that we good so far? Okay, this is how it's organized. So imagine you have arterial. I'll explain what I'm drawing in a second. Postcapillary venule. This is called thoroughfare channel. This is called net arterial. Those are capillaries. Okay. Now, each capillary is controlled by a sphincter. You see the precapillary sphincter? So this is how the tissue perfusion works. Blood flows through arterial, gets into the medarterial. That makes sense? If sphincters are open, blood gets into the capillaries. We good? It also flows through the thoroughfare channel, but eventually all that blood goes into the postcapillary vein. Got it? Let's say for some reason you want no perfusion for the tissue. You need to spare some blood. These precapillary sphincters close, Is there any perfusion? No. Can blood still go from arterial to venule? Yes. This is called a vascular shunt or vascular anastomosis. This is arteriovenular anastomosis. If you would look at your forearm, or my forearm for that matter, I don't know if you can see, this large vein here, it's median antecubital vein. It's a venular anastomosis between the brachial, no. Brachial, radial and ulnar, but I'm not sure. I can't get it. Okay. Between a couple of veins in the floor. There are arterial anastomosis. Many of them are in the corner circulation. Okay. Between basilic and cephalic. That's what I was. Basilic and cephalic. Okay. Does that make sense? There are a lot of anastomoses that create other paths for blood. Good so far? And this different categories explain why different capillary beds are different, because capillaries are different. We good? Last little bit, and I'm going to grab the model there. So the structure of the vascular wall. Arteries and veins. Tunica intima. Which is endothelium. Here on the model, okay, this is artery, can you see that? Those are veins. So tunica intima is basically this endothelium. It's a simple squamous epithelium, cells that line it in the inside. Does that make sense? Tunica media. Smooth muscle. Now compare the vein and the artery. Look at this. That's the artery. See how thick the muscle level is? You see how well it keeps the shape? Okay, that's your tunica intima here. Tunica media, I'm sorry. In veins, not so much. A little bit of muscle, not a lot. Got it? And finally, tunica externa. It's connective tissue. Pretty elastic. So that is basically tunica externa here. Now, something that I want to highlight, very, very specific for you. It's not really a good one. So I will not use the model to highlight it, but I'll explain. So the vessel walls in the large vessels, like the aorta that you saw today, you saw the aorta, right? It is noticeably thick. It's like a couple millimeters thick. Am I clear? So oxygen from the blood cannot diffuse all the way through 2 millimeters. Does it make sense? So walls of big vessels have their own blood supply. Their own tiny little blood vessels that are collectively called, and I'm going to just put it somewhere just as a term, it's called vasa vasorum. blood vessels that supply oxygen to the walls of blood vessels. We good? Clear? Awesome. What about capillaries? Capillaries do not have all those tunics, technically speaking. They have endothelium and basement membrane. All right? So the walls are very thin. Okay? They have layer of endothelial cells and a basement membrane. Now look, in continuous, think of it this way. Imagine that those endothelial cells here, they're like tiles, okay? Just like tiles next to each other. So in continuous capillaries, those tiles are very tight. In fenestrated, there are gaps, there are openings, there's transport going on. In sinusoid capillaries, tiles are very loose. So exchange is easy. Does it make sense? Now, I think that's kind of wraps it up. I have one question. Well, not curious. Work with. What is the diameter of a capillary? How wide is a capillary? The answer is not in numbers. Compare it to some objects. How wide should be a capillary? Huh? No, much smaller. No. Object related to cardiovascular disease. What is the purpose of a blood vessel? What do we need blood vessels for? Huh? How? Huh? Yeah, so there's blood flowing through the blood vessel, right? So what is the diameter of the smallest vessel? Bingo. It should be as not smaller than the size of the blood cell. Does that make sense? And it's as the blood cell. If you actually, I have some videos up. I'll see if I'm able to show. Some of those videos are actually in the lecture notes, but I'll check if I can access some of my old videos. When you look at the blood flow through the capillary, it's not a flow. Like you look at artery, you cannot see a single cell. Even look at the veins, and unless cells are stuck to the wall, you cannot see cells. Does that make sense? Look at the capillary, it's like people in a subway, like pushing through, you know? It is really slow, and that allows for an efficient exchange. Any questions? We're going to stop at this point. We're going to talk about blood pressure and exchange in the tissues next week. Maybe starting blood. We'll see.